Okay.
Where
So
do the carotid sinus locate?
carotid body, uh, carotid body locates in the posterior to bifurcation of the common carotid artery, and it contains chemoreceptor, so it helps in control of respiration. And carotid sinus, it is at the root of the internal carotid artery, and it contains the baroreceptor, so it helps in control of blood pressure.
Okay. Which nerve lies just lateral to external carotid artery and just
Okay,
superior
you
to
you
the
can take this
bifurcation?
discussion, Doctor. Remaining you can take, Doctor
Oh,
Esra.
which nerve lies just lateral to external carotid artery? A hypoglossal nerve.
Okay,
What's
and
the
okay, I will ask you the question.
mm,
What is the deficit occur if it is injured?
a movement of the one half of the tongue at the same side?
Anything else?
Paralysis. Mm?
Anything else?
Deviation, deviation of the tongue uh,
To which side? Deviation of
Mm.
tongue.
to
If
the
hypoglossal nerve is
to the,
injured,
to the opposite side.
Contralateral side.
okay. Anything else? Four, total four. Okay, once we finish, then we will discuss. Pointing to the facial artery, could this structure be ligated without developing ischemia to its target organ tissue?
Yes, because of numerous anastomosis from the contralateral side.
Okay. Pointing to the submandibular gland, where does it open? This gland open during that?
Submandibular in the floor of the mouth beside the frenulum.
Which mouse? You said mouse. This is typical
Mouth.
Egyptian accent. Okay. 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 Pointing to submandibular gland, where does this gland open?
Done.
Okay. And pointing to parotid gland, where does this gland
Bar-
open?
Parotid gland in the uh, oral vestibule at the level of upper second molar.
Um,
I think it should be
Uh,
duct and not gland.
yes, it should be dark. It is not the gland, it is dark. Yeah.
it passes above masseter and pierces buccinator.
And where does it open?
Opposite to the second upper second molar
Yes, opposite.
teeth.
Second upper molar tip. And what is the type of secretion of the salivary gland?
Serous secretion.
Okay. Can you mention name of some salivary gland?
Mention name of
Some salivary gland.
parotid, submandibular, lingual.
Okay. Submandibular, sublingual. Okay. Okay. Regarding the function, you answered correctly. Regarding the hypoglossal nerve, if because what is the normal function of hypoglossal nerve? Normally, hypoglossal nerve gives supply motor function to the tongue
Vibration.
muscle, right?
Mm.
And hypoglossal nerve,
Mm.
how many are there? Hypoglossal nerve, suppose this is tongue, and hypoglossal nerve will give supply to motor function. We have hypoglossal from both sides, right? Like this. So if this side hypoglossal nerve is injured, this side muscle will be paralyzed. I mean, motor function will be paralyzed. So loss of motor function of the ipsilateral side, the same side. This side, tongue's motor function will be affected, and tongue will be deviated to the opposite side. This is the fact. We need to be careful because motor function will be affected in the ipsilateral side, and as motor function is uh, uh, affected, what will happen? Tongue will be deviated to the affected side. Okay, it will be deviated as it is injured this side. Shall I explain this thing? And loss of side to side movement. Tongue cannot move side to side because this side motor function is lost. So loss of side to side movement affected. Also, there will be atrophy because of the motor function loss. So fourth thing, one is loss of motor function of the ipsilateral side of the tongue. Tongue will be deviated to the affected side. Number three, loss of side to side movement. And number four, atrophy, tongue atrophy. Other answers you answered properly. Very good. Okay, now Dr. Asma, you can take this situation. Identify structure number 1. Here is structure number 1. Hello.
Hello.
Yes. Identify structure number 1.
It is the azygous vein.
Okay. Structure number 3.
Branch of the splenic nerve.
Okay. Number 24. Here is 24.
I can't see it. Can you? Where is 24?
Here is 24. I'll make a little larger. If you are joining from mobile, you can zoom in your mobile screen.
What? Sorry?
If you are joining with the mobile, then in the mobile you can make the screen larger, zoom. You can zoom
Okay.
here, and this is 24.
Okay. 24 is the it is okay. It is superior vena cava, I guess.
Yes, it is superior vena cava. And 27, this is 27, 27, 27. These all are 27.
Yes, it is a sympathetic trunk.
Yes. With sympathetic trunk with
What?
ganglion. Sympathetic trunk with ganglion.
Okay.
And number 3, you say this is splanchnic trunk. Mainly they are forming, this is number 3. See, number 3, number 3, number 3. These are forming greater splanchnic nerve. Greater splanchnic nerve. So you can say number 3 is the
Okay.
branches of sympathetic trunk to greater splanchnic nerve.
This number 3 is the greater splanking, you mean?
Yes.
Okay.
And they are the branches of the
27 is the
sympathetic trunk.
27 is the
the
sympathetic.
sympathetic trunk with ganglion.
Okay.
Okay, so
Okay.
what are the boundaries of posterior mediastinum?
The bounds of posterior mediastinum. Okay. Laterally, medially, we have the mediastinal pleura and the hilum. Sorry, mediastinal pleura and posteriorly we have the lower eight thoracic vertebrae. Mm, um, and
Mention the name of the line separating it from the superior mediastinum.
the name of the line.
Mhm.
No, I don't know the name.
This
It's
is
a
a imaginary line, or you can say transverse thoracic line.
transverse thoracic line.
Yes. And from where?
I don't know if I have a name. Okay, yes.
Okay. And from where it goes and up to where? Transverse thoracic line.
Sorry.
Transverse thoracic line. What is the surface anatomy of this transverse thoracic line?
Okay, is it an imaginary line for joining the between the fourth and fifth thoracic vertebrae to the
Okay.
sternum,
Angle of Lewis.
Angle of
to the
Lewis.
angle of Lewis. Okay.
Yes. Either manubrium sternum or angle of Lewis to the lower border of thoracic four vertebra. Okay. Mention 6 structures that lie in the posterior mediastinum.
Okay. We have the vagus nerve, the gluteus planking nerve. We have the esophagus. You want 6 structures?
Yes.
We have also, I said the esophagus, the vagus, the splanking, the sympathetic nerve, and the azygos also,
Yes.
and the thoracic duct.
Yes.
Okay, I think that is 6.
And
One
a
important
big
structure.
structure. Yes. Big one. You are denying.
What?
A big structure.
The thoracic duct?
You already told. Okay. So yes, Dr. Pardus, can you please answer this question? Bedrose.
Descending aorta.
Mm-hmm.
Very
Mention all
important.
6 structures. Descending aorta and then
Descending aorta, esophagus, azygous vein, sympathetic chain.
and thoracic duct. Also, she said
And
vagus
thoracic
nerve.
duct, yes, of course.
Yes.
Vagus nerve.
Okay. What are the complications of perforation of the esophagus? Yeah, Dr. Asma, continue.
Okay. All the same problem. All these esophagus questions in my pocket is with the abdomen. I didn't do
Okay.
it.
Esophagus goes
No.
through the thorax, then it goes to
What?
I mean esophagus. It has contribution in thorax also. So in thorax topic also we will get esophagus.
Okay. I know it's related, but I didn't prepare it because it is with the abdomen.
No problem.
Can I answer this question?
Okay,
Yes,
you can.
please.
Mediastinitis, very easy.
And
Mm,
esophagus
I don't
rupture.
remember.
Yes, one is mediastinitis.
Borham syndrome.
perhaps also yes, and sepsis, perforated
Sepsis, of course.
esophagus. Yes, sepsis, medistinitis, esophagitis, Wartburg syndrome. We can say all of this. Okay. So, what is the type of epithelium of the esophagus?
Should I answer or should she answer?
No, doctor, you
Mm,
can answer the rest of the questions. I have no problem.
Non-keratinized stratified squamous epithelium.
okay. And where does esophagus begin at?
T6. Excuse me,
And
C6.
C6, yes. And where does it end?
Where does it where does it end?
Mm-hmm.
It ends at T12.
T12. At which level it fires the diaphragm? Esophagus at which level fires the diaphragm? In the next picture, you
T10,
can see nicely.
excuse me, T10.
Yes. Uh, your answer also right, but if you can answer it in this way, esophagus fires the diaphragm at T10 and it join with stomach at the level of T12. That is also correct.
Yes.
Okay. And now, what is the bony landmark of this beginning of esophagus?
Or it should be the cricoid cartilage.
Cricoid cartilage. Now, what are the parts of the diaphragm? What part of the
Left
diaphragm the esophagus pass?
left crus.
Sure? Are you sure? It is left?
It should. Sorry, excuse me, right crus.
Yes, it is right. Right crus of the diaphragm. What is the blood supply of the esophagus?
It has the upper 1/3 is from the inferior thyroid artery, which is a branch of the thyrocervical artery, thyrocervical trunk. The middle 1/3 is from the esophageal branches, from the descending aorta, and the inferior part is from the left gastric artery.
Left gastric artery is a branch of
Left gastric artery is a branch of the celiac trunk.
celiac trunk. Yes, and venous drainage.
Venous drainage, the superior part is from the inferior thyroid vein. The middle part is to the azygos vein, and the inferior part is to the left gastric vein.
And what is the lymphatic drainage of esophagus?
Oh, I cannot say this. I've forgotten this.
Dr. Esra, you want to answer this one? Lymphatic drainage?
lymphatic drainage of esophagus.
Yes.
Uh, deep first third deep cervical, middle third mediastinum, lower third left gastric lymph node.
Okay. Okay. What is the nerve supply to of the lower part of the esophagus? Anyone can answer? Nerve supply of lower part of the esophagus. For
Should be the
me,
vagus nerve.
it is a difficult question for me. I always make mistake. It is divided into like sympathetic and parasympathetic. Sympathetic and
Mm.
parasympathetic. So sympathetic and parasympathetic. Sympathetic from thoracic 5 to thoracic 11 and parasympathetic by vagus. Which vagus? Right. Right vagal trunk. RV.
Right vagus.
Right. Yes. So right vagal trunk. Parasympathetic and sympathetic by thoracic 5 to thoracic 11. Okay. Mention two structures leave an indentation in it.
The left main bronchus and the left atrium.
Yes. And Aortic arch also. Left,
Aortic arch, of course, yes.
yes, left principal bronchus, left atrium, and aortic arch. Okay. What is the most common esophageal tumor?
Adenocarcinoma.
Most common esophageal tumor. Squamous. Squamous cell carcinoma. Most common.
Mm-hmm.
Okay. So what happens in Barrett esophagus? What happens in Barrett esophagus?
Oh,
And what is the epithelium
wait.
type in Barrett esophagus?
We have reflux of gastric contents and intestinization of the esophagus. Well, first we have
So,
reflux esophagitis, which then turns into dysplasia, which then turns into Barrett's esophagus.
so here we need to mention like this: the change of normal stratified epithelium to columnar epithelium, also goblet cell due to
Mm-hmm.
chronic acid reflux. In Barrett esophagus,
Yes.
two things is a must. One is metaplasia. Which metaplasia? That is squamous metaplasia to columnar, also goblet cell. When this columnar cell and goblet cell present, then it will be regarded as Barrett esophagus. Okay. What's the nerve that pass right to the thoracic trachea? Hello, Dr. Vesta, you can answer. What is the nerve that pass right to the thoracic trachea?
vagus nerve.
Which vagus?
Right.
Yes. So it is right because they are asking right to the trachea. So as we have two vagus, right to the trachea would be right vagus nerve. What level of the spinal cord does sympathetic trunk contribute to? It is thoracolumbar outflow, that is thoracic 1 to lumbar 2. What communicates the spinal root and post-ganglionic fiber?
Gray ramus
And
and white ramus.
gray ramus and white ramus communicans. Gray ramus communicans, white ramus communicans.
Yes.
And what are the tributary of Ajaga system?
I have to revise these. It's been 2 months.
But you remember everything. Very okay. So, who want to answer? On the plasma, you remember this one? Ajagas vein.
Yes, it is the right superior intercostal vein, hemiazygous and accessory hemiazygous, mediastinal, pericardial, esophageal, also the lower right posterior intercostal vein. I said esophageal and bronchial.
Okay. So it is pericardial vein, esophageal vein, mediastinal vein, bronchial vein, hemiazygous and accessory hemiazygous, then right superior intercostal vein and right lower posterior intercostal vein.
Yes.
Okay. Okay. Well done. We have finished thorax, and now we will go to phone call communication. Today we
Okay,
had
guys, Excuse me,
Yeah,
I'm going to leave you for today.
sure,
Maybe
doctor.
I will see you
Sure,
tomorrow. Okay?
sure, doctor.
All right. Good night.
Have a
Bye
good
bye.
night. Good night. Yeah, bye. Phone call communication. You prepared, Dr. Asma? Hello? Hello? Can you hear me, Dr. Asma? Uh, okay, Dr. Esra.
Mm.
Okay, so you can start. Maybe Dr. Asma, she is a little busy. You can start and she can do next time. Can you see the screen?
Loading. Yes.
Okay, so this is the station. In real exam, it will be a big file of you can say 7 to 8 pages as like a admitted patient. So many notes will be there when patient first consulted, then when junior doctor seen, when senior doctor seen, what was the lab test, what was the operation done. So many details will be there, and from there, this is a summary. Okay, and this summary actually we have to prepare by ourselves. In the exam stem, it will not be given like this. They will give a big, like a different type. It will be something like this. You can see the screen,
Yes.
and there will be time given for 9 minutes. In this 9 minutes, you have to go through all the pages. Very rapidly, you go through and make your own note. Make your own note. Okay. If you open this page, first you see who has written. This is consultant surgeon. What he has written and when he has written. He has written it at this time. What was the thing? Bleeding per rectum, weight loss 7 kg in 6 months, and these are the vitals, and for colonoscopy and CT abdomen. Okay. Then colonoscopy done by a junior doctor, and it was the finding. Then registrar has seen, and this is his thing. Then this is the OT note and some description of the OT note. Then post-operative review about the investigation and fluid chart, urine output, this thing. Then investigation report. All reports are there. Like this type of file will be there, and you have to make your own note. According to that, it is a ready-made format. Now you can read the station, and Dr. Asma, you are there. Hello. Uh,
Yes,
okay,
yes, I'm here. Yes.
okay. So you can be her consultant.
Okay.
Okay, so yes, Dr. Isra, you can go through the station.
Okay, set a timer.
Uh, uh, you, we have already 9 minutes. So in this 9 minutes, you have to finish
Okay.
before the meeting finishes. Auto timer
Okay.
started. Yes, please start.
Start, Isra.
Post operative day 1 patient following laparoscopic left hemicolectomy for colon cancer with liver biopsy, clinically tachycardia, mild hypertension, mild feverish. Patient looks dehydrated, abdominal examination unremarkable, urine output 10 milli per hour for last 8 hours, urine catheter is not blocked, hemoglobin dropped from 12 to 10, create 116, ECG, chest X-ray are normal. Post-operative day 1 received only 1,100 ml of normal saline. received 2 units of blood intraoperatively. You are surgical senior house officer working for Mr. Man, who is currently on annual leave. Hello, I am Dr. Isra, senior house officer. I am calling on-call consultant to ask for his advice about the patient undergone right laparoscopic right hemcolectomy and liver biopsy 24 hours ago. Can I check if I calling on-call consultant?
Okay, who is the consultant of the case?
Mr. Man.
Summarize your case, please.
Mr. John, 70-year-old, undergone right laparoscopic hemcolectomy for vertical carcinoma and liver biopsy.
Left in the case. Left in the case we have here. Left hemcolectomy.
Left, yes, left hemicolectomy.
Right? Okay. Cecal, how to be cecal. Okay.
Okay, continue, please.
He is clinically tachycardic, mild hypertensive, with looked dehydrated, and his abdomen is lax. His investigation, hemoglobin dropped from 12 to 10, and his urea is moderately elevated, and create borderline, and ECG and X-ray are normal.
You didn't tell me what is the problem of your patient.
So
Very good question. Very good question. Okay.
He looked dehydrated and oliguric, but on 10 milli per hour. I checked his Kester, it's not blocked.
What mean by look dehydrated? I mean, what is his urine output?
I'd say 10 milli per hour.
In how many hours?
In the last 8 hours.
Okay.
Okay.
What do you think the cause is?
Patient is dehydrated as he received only 1,100 milli normal saline for the first day post-operative, and I checked his data. He lost big amount of blood and received 2 blood units.
Okay. What is your what did you do? What's your plans of action?
We will start with the fluid challenge by giving 250 milli normal saline in 15 minutes, and continuously assess his responsiveness. If there is no response, we can repeat 2 or 4 times, and continuously re-observe. If there is no response, we will plan to transfer to a high dependence unit and insertion of central line, and taking another blood samples the next day. If there is no response, we may go for re-exploration.
Do you think the patient is bleeding?
Yes, because he is tachycardic.
What
Skip,
will you do
skip
for
that.
him?
Hmm?
What will you do for him? Now you think the patient is bleeding. What will we do?
Uh, we will assess his vital signs, heart rate, blood pressure, capillary fill, mental status,
What
and
else?
urine out.
What else?
Then do repeat the investigation. Blood blood samples
And you
for
will
the
leave the
next.
patient. And we will leave the patient bleeding until the results of investigation are. What will you do for the patient? If you think he has an abdominal bleeding, what do you do for him clinically?
Clinically assess abdominal laxity and prepare for abdominal ultrasound.
Do you think he have an stomach leak? An stomatic leak?
No, his abdomen is lax and he is not toxic.
So you did an abdominal examination?
Yes,
Okay. Will you repeat the abdominal examination or not?
yes.
Okay, what else will you do for the abdomen?
I don't know.
Will you do an ultrasound for him or not?
Yes,
Okay. Do you think the patient had peritonitis?
peritonitis. Till now, he hasn't. Uh,
Okay, do you want me to come back?
till now, we can manage. We will do fluid challenge and reassess. And if there is any signs for peritonitis, we will let you know.
Okay, and what is the causes of shock in this patient?
Sepsis and hypovolemia.
Does he require high dependency unit transfer?
Till now, no. We will reassess for his vital signs.
Does he require operation now?
No.
Okay. So tell me what to do. What the fluid challenge will you do to him? The dose?
In 30 milli per kg.
Okay. Of what?
Normal saline.
Okay. For how long?
15